This series is about health policy, not ideology. Decisions about healthcare in the United States are often discussed as political abstractions, talking points, slogans, and personalities. But their consequences are not abstract. They show up in emergency rooms, schools, workplaces, and kitchens. They show up in who gets care, when they get it, and at what cost. Most people do not distrust medicine because they reject science. They distrust it because they have been confused, overbilled, and talked past. Medicine is complicated, insurance is opaque, and explanations are often delivered in jargon that obscures rather than clarifies. A simple example: when a Medicare plan is canceled and replaced with alternative options that appear nearly identical, except for a substantially higher premium, the consumer is left with paperwork, terminology, and reassurances, but little concrete understanding of what actually changed or why. Experiences like this are not rare, and they are not ideological. They are structural. Over time, this kind of complexity erodes trust. That erosion did not begin with any single administration or crisis. It developed gradually through cost opacity, administrative layers, and systems that demand compliance while struggling to communicate clearly. When trust weakens, something predictable happens. Expertise begins to compete with confidence. Repetition replaces evidence. Policy debates shift away from institutions and toward individuals. In that environment, it becomes easier to confuse rhetoric with action and harder for citizens to recognize when real decisions are being made. This series is not an argument for or against any party, personality, or program. It is an examination of how health policy is framed, funded, and implemented, and how those choices shape outcomes regardless of intent. Each piece will also include practical guidance on what signals matter, what patterns to watch for, and where individual citizens still have meaningful influence, not as activism and not as instruction, but as civic literacy. Health policy is not theoretical. Understanding how it works, how it breaks, and how it is communicated is one of the few forms of leverage people still have when the stakes are this personal. Health policy is often discussed either at a level so abstract that it feels irrelevant or so emotional that it becomes exhausting. In both cases, people disengage, not because they don't care, but because they can't see where their understanding actually makes a difference. The purpose of this series is to examine how health policy decisions in the United States are framed, funded, and communicated, and how those processes shape outcomes regardless of political intent. Rather than advocating for specific programs, candidates, or ideologies, this series focuses on identifying patterns, how trust is built or lost, how complexity can clarify or conceal, how rhetoric diverges from operational reality. These patterns matter because health policy is not a single decision or law. It is an ecosystem of incentives, funding mechanisms, administrative choices, and public narratives. Once those systems are in motion, outcomes follow whether or not anyone agrees with them. Why this matters now. Many people sense that something about healthcare feels increasingly unstable, but struggle to articulate why. Costs rise without explanation. Coverage changes without clarity. Experts speak, but confidence spreads faster than evidence. This series does not assume bad faith. It assumes systems under strain. Understanding how those systems work and how they fail is more useful than reacting to any single headline. It allows readers to recognize warning signs earlier and to distinguish noise from signal when stakes are high. What this series will and will not do. This series will examine policy outcomes without assigning personal motive. Use real examples to illustrate structural dynamics. Move deliberately, one concept at a time. Include guidance on what signals matter and where influence exists. This series will not offer voting advice or endorsements, react to breaking news, reduce complex systems to villains or heroes, use parody or satire to make its case. The goal is understanding, not alignment. How this will unfold posts will be short enough to digest in one sitting and structured to build on one another. You do not need to read them all at once, and disagreement is expected. The series begins with a simple question. How did health policy become a trust problem? Before examining any administration, crisis, or reform effort, it is important to understand why trust weakened in the first place, and what happens when it does. That is where the series begins. Next, trust became the weak point.
Part 1. Trust became the weak point. Public health systems depend on trust in ways that are easy to underestimate. Not blind trust and not perfect trust, but enough confidence that people believe guidance is given in good faith, decisions are explainable, and errors are acknowledged rather than obscured. In the United States, that foundation weakened long before any recent crisis or political figure. It weakened quietly, through everyday interactions that felt small at the time but cumulative in effect. Most people did not stop trusting healthcare because they rejected science. They stopped trusting it because the system became harder to understand, harder to navigate, and harder to believe was working in their interest. Complexity without clarity. Healthcare in the US is genuinely complex. That complexity is not itself the problem. The problem is that complexity is often presented without translation. Insurance documents describe coverage in terms of tiers, codes, networks, and contingencies that are difficult for even attentive readers to interpret. Changes are communicated through dense notices that explain what is happening without clearly explaining why or what it means in practice. When plans are canceled and replaced with alternatives that appear nearly identical, except for higher premiums or different cost sharing, people are left with terminology rather than understanding. Over time, repeated experiences like this create a sense that explanations are designed to satisfy requirements, not to inform. That gap matters. Cost as a trust erosion mechanism. Trust is also shaped by predictability. Few things undermine confidence faster than discovering the true cost of care only after it has been received. Surprise billing, opaque pricing, and inconsistent coverage rules train people to expect uncertainty. Even when care is technically available, the fear of unknown cost changes behavior, delaying treatment, avoiding follow-ups, or disengaging entirely. This is not an ideological response. It is a rational one. When people cannot anticipate consequences, they stop believing assurances. Institutions that speak poorly under pressure. As systems grew more complex, institutional communication often became more defensive. Language shifted toward legal precision and risk avoidance rather than clarity. Explanations became longer but less informative. Mistakes were corrected quietly, if at all. Accountability was diffused across agencies, insurers, providers, and administrators, each technically accurate but collectively unhelpful. Over time, this creates a vacuum. When institutions struggle to explain themselves, others step in to explain for them. What happens? When trust weakens. When trust erodes, several predictable shifts occur. Expertise must compete with confidence. Repetition begins to substitute for evidence. Personal narratives feel more credible than institutional ones. Individuals become symbols for entire systems. None of this requires malice or conspiracy. It is how people adapt when clarity is missing and stakes are high. By the time a crisis arrives, the groundwork has already been laid. The public is primed not to evaluate guidance on its merits, but on whether it feels consistent, confident, and aligned with prior experience. Signals to watch. As this series continues, it helps to notice a few early indicators of trust strain. Explanations that grow longer but clearer on none of the practical details. Language that emphasizes compliance without understanding. Corrections that appear quietly, without acknowledgement. Complexity that increases without improving outcomes. These signals often appear well before policy consequences become visible. Why this matters going forward. Health policy does not fail all at once. It frays. Trust is usually the first strand to weaken, not the last. Once it does, Every subsequent decision, no matter how well intentioned, faces skepticism, resistance, or distortion. Understanding how that erosion occurs is essential because it explains why later debates become less about evidence and more about narrative. That is where the series goes next. Next, when expertise became personal. Part 2. When expertise became personal. Public health expertise was not always controversial. For decades, it functioned largely in the background, technical, imperfect, and mostly invisible. When it worked, few noticed. When it failed, corrections were usually quiet and procedural. That changed when expertise became personal. As trust in institutions weakened, authority began to migrate away from systems and toward individuals. Complex guidance was no longer evaluated primarily on evidence or process, but on who was delivering it and how consistently. This shift did not require a coordinated effort. It was a natural response to confusion. When institutions struggle to communicate clearly, people look for human proxies they can assess intuitively, from institutions to individuals. Institutions speak in committees, caveats, and revisions. Individuals speak in faces, voices, and confidence. In an environment already strained by complexity, the latter often feels more accessible, even when the underlying information is less complete. As a result, public health authority increasingly became embodied in specific figures. Scientific disagreement, which is normal and necessary, was reframed as personal inconsistency. Updated guidance, which reflects learning, was recast as unreliability. This personalization made expertise easier to attack, defend, or dismiss. A system can absorb critique. A person cannot without becoming the story. Why personalization works. Personalization simplifies judgment. Instead of evaluating methods, data, and uncertainty, people are encouraged, often unintentionally, to evaluate tone, confidence, and perceived alignment. Once expertise is tied to individuals, disagreement feels like betrayal. Revision feels like deception. Nuance feels like weakness. This dynamic is especially potent in public health, where uncertainty is unavoidable and recommendations evolve as evidence accumulates. The cost of making experts, the message. When individuals become symbols for entire systems, consequences follow. Debate shifts away from institutional capacity, funding, and preparedness, and toward loyalty or opposition to particular figures. Questions about infrastructure and decision-making are replaced by arguments over credibility and character. This does not improve understanding, it narrows it. Over time, public health guidance becomes harder to evaluate on its merits because it is no longer received as guidance, it is received as advocacy. What to watch for. As this series continues, notice when policy disagreements are framed around personalities rather than processes, critiques focus on tone or consistency rather than outcomes, individuals are treated as proxies for complex systems, institutional failures are personalized instead of examined structurally. These are signs that expertise has been detached from the institutions that support or undermine it. Why this matters. Going forward, once expertise becomes personal, it becomes fragile. Removing or discrediting an individual can feel like resolving a systemic problem, even when the underlying structures remain unchanged. This creates an opening for rhetoric to replace capacity and confidence to replace preparation. Understanding this shift helps explain why later public health debates become less about evidence and more about allegiance, and why restoring trust is far more difficult than losing it. That dynamic becomes clearer in the next phase of the series. Next, repetition as policy signal. Part 3A, when this happened before. Before this series goes any further, it's worth pausing to show that what we are describing is not new and not partisan. Long before COVID, long before Trump, and long before modern media ecosystems, the same policy pattern played out around tobacco. This matters because it reveals how policy can be shaped without ever being formally decided. The tobacco pattern. For decades, the health risks of smoking were not unknown. Doctors observed higher rates of lung disease, Epidemiologists saw correlations strengthen year after year. Internal industry research, later revealed, often confirmed the danger. Yet public policy stalled. Why? Because the dominant message repeated to the public was not that smoking was safe, but that it was uncertain. More research is needed. The science isn't settled. Correlation isn't causation. None of those statements were outright lies. That's what made them effective. They created just enough doubt to justify inaction. Repetition as delay. This is the critical mechanism. The message didn't need to persuade people that cigarettes were healthy. It only needed to persuade policymakers and the public that acting now would be premature. Each repetition reinforced a sense of responsible restraint. Waiting was framed as prudence, delay was framed as neutrality, action was framed as overreaction. Over time, delay itself became the policy. No single announcement said, "We choose not to regulate," but the repeated framing ensured regulation would always be postponed. The cost of waiting. The human cost accumulated quietly. Smoking-related illnesses rose predictably. Generations adopted a habit already known to be dangerous. The burden fell disproportionately on working-class families, veterans, and rural communities, long before those terms became political shorthand. By the time policy finally caught up, millions of lives had already been affected. No one could point to a single decision that caused the harm. That, too, was part of the design. Why this example matters now. Tobacco shows how repetition substitutes for policy. When uncertainty is repeated often enough, it becomes permission. When delay is normalized, it feels responsible. When action is framed as reckless, inaction feels safe. This is not about cigarettes. It is about a pattern. Setting up the next step. Once you recognize this structure, you start to see it elsewhere, especially in health policy. Not through detailed plans, not through legislation, but through repeated language that signals what will not happen. In the next section, we'll examine how repetition itself functions as a policy signal, and why hearing the same claim again and again is rarely accidental. Next, Part 3b, Repetition as Policy Signal. Part 3b, Repetition as Policy Signal. One of the easiest ways to miss what is happening in health policy is to listen only to what is being said, not how often it is being said. Repetition is not accidental. In politics, it often functions as a substitute for action. When leaders repeat the same reassurance, promise, or dismissal over and over, without new details, timelines, or mechanisms, it usually means one of three things. The policy does not exist yet. The policy exists only as a concept, not a plan. The policy is unpopular or impractical, and repetition is being used to delay confrontation with that reality. This is not unique to any party or moment. It is a structural behavior. Repetition fills the space where legislation, funding models, or regulatory language should be. You can hear it in phrases like, "We're working on it," "It will be addressed very soon," "Trust me," "You'll see." When these phrases appear once, they may reflect genuine uncertainty. When they appear repeatedly over weeks or months, they become signals. The tobacco era showed this clearly. For years, the same reassurances were offered while evidence mounted. No new information was added, only the same language, restated. The repetition was not meant to inform, it was meant to delay. This is where readers can begin to exercise real agency. Instead of asking, "Do I agree with this?" ask, "Has anything new been said since the last time this was promised? Has the explanation become more detailed or stayed vague? Has responsibility shifted from institutions to individuals? Has repetition replaced accountability?" These questions require no ideology. They require only attention. In health policy especially, repetition matters because delay has consequences. Costs rise, coverage gaps widen. People make decisions based on what they believe is coming next. Recognizing repetition as a signal, not reassurance, is one of the first practical tools citizens have to protect themselves in complex systems. Tomorrow, we'll look at how responsibility quietly moves from public systems to private individuals, and why that shift often goes unnoticed until it's too late.
A real-time example, why markets react faster than voters. In a surprise move, the Trump administration's Centers for Medicare and Medicaid Services, CMS, proposed a near-flat 0.09% increase in payment rates to private Medicare Advantage, MA, plans for 2027, far below Wall Street expectations of 4 to 6% and following a more generous 5.06% boost for 2026. The announcement triggered an immediate sector sell-off the following day, with major insurers losing double-digit percentages in market value, led by sharp declines across the Medicare Advantage space. Analysts cite tight insurer margins, rising medical costs, and efforts to curb overbilling, including changes to risk adjustment excluding certain chart reviews, as reasons the minimal increase could force benefit cuts, higher enrollee costs, or plan reductions for the more than 35 million seniors enrolled in MA plans. Industry groups warn of potential disruptions when 2027 coverage renews in late 2026, though final rates will not be set until April. This adds pressure to an already challenging Medicare Advantage landscape, where many plans have recently faced premium increases, benefit adjustments, or network changes. What matters here is not the stock reaction itself, but how quickly payment signals translate into market behavior, a dynamic we've been examining throughout this series. For beneficiaries, this is a reminder to pay close attention to annual notice of changes documents and enrollment windows, particularly if plan costs, benefits, or provider access begin to shift.
Part 4. When responsibility moves quietly. When health policy stalls, something important happens that is easy to miss. Responsibility doesn't disappear, it moves, and almost always it moves away from systems and toward individuals. This shift rarely arrives with an announcement. There is no press conference declaring that people are now on their own. Instead, the change shows up gradually, wrapped in reasonable language. Words like choice, flexibility, consumer-driven, personal responsibility. On their own, these words sound empowering. In practice, they often signal something else. What happens when policy pauses? When governments delay, defer, or avoid clear health policy decisions, the system still has to function. Care still costs money. Providers still need to be paid. Insurers still need to price risk. Employers still need to decide what they will offer. In the absence of coordinated policy, the burden of navigating those decisions shifts downward. From institutions to employers, from employers to families, from families to individuals. No one votes on this transfer. It happens quietly through defaults. How choice becomes a signal. Choice is not inherently bad, but when choice expands while guidance, coverage, or protection does not, it becomes a signal that responsibility has shifted. Instead of asking, "Is this covered?" people are asked to consider which plan, which network, which deductible, which out-of-pocket maximum, which exclusions. These are not choices most people can make with confidence, especially under time pressure or medical stress. Yet the presence of choice creates the impression that outcomes are the result of personal decisions, not structural design. The human experience of the shift. Most people never engage with health policy directly. They encounter it at moments of vulnerability, a job change, a pregnancy, a diagnosis, a cancellation notice, a premium increase. At that point, the question isn't ideological, it's practical. Am I covered? Is my family covered? What happens if something goes wrong? When responsibility has already shifted, the answers are often unclear, not because people weren't paying attention, but because the system expects them to manage complexity that used to be handled upstream. Why this shift often goes unnoticed. The transfer of responsibility feels normal because it happens gradually. Each step can be justified. Employers reassess costs, insurers adjust plans, governments emphasize flexibility. No single change looks unreasonable, but taken together, they redefine who bears the risk. By the time people realize what has happened, the system presents the outcome as a matter of personal choice rather than public design. Setting up what comes next. Once responsibility moves to individuals, complexity becomes the gatekeeper. Understanding plans, coverage limits, and trade-offs becomes essential and increasingly difficult. In the next part, we'll look at the difference between having choices and having meaningful coverage, and why those two things are often confused. Next, Part 5, Choice versus Coverage. Part 5, Choice versus Coverage. After responsibility shifts to individuals, the system offers something in return. It offers choice. At first glance, this feels like a fair trade. More options suggest more control. More plans suggest better fit. More flexibility suggests empowerment. But choice and coverage are not the same thing. Confusing the two is one of the most common and costly misunderstandings in modern healthcare. What coverage actually means? Coverage answers a simple question. When something goes wrong, will care be there, and at what cost? It is about predictability, risk pooling, protection from catastrophic expense. Good coverage reduces uncertainty. Choice, by contrast, often increases it. How choice expands as coverage thins. As responsibility moves away from systems, people are asked to select from multiple plans, multiple networks, multiple deductible levels, multiple cost-sharing structures. Each option appears reasonable in isolation. Taken together, they create a decision environment where trade-offs are hard to evaluate, consequences are delayed, mistakes are discovered only after care is needed. The presence of choice creates the impression that outcomes are the result of informed decisions, even when the information required to decide well is unavailable or unintelligible. Why this isn't a normal market. In most consumer markets, you can compare prices, you can test quality, you can change providers easily. Mistakes are reversible. Healthcare works differently. Decisions are often made under time pressure, without full information, during stress or illness, with limited ability to switch later. Choice without usable information is not empowerment. It is exposure, the emotional cost of choice. When outcomes are framed as the result of personal choice, people internalize failure. Confusion becomes guilt. Unexpected bills become regret. Coverage gaps feel like personal mistakes. This emotional burden discourages people from seeking care, asking questions, or challenging outcomes, reinforcing the system that created the confusion in the first place. What to listen for going forward. When you hear health policy framed around expanding choice, it's worth asking, is coverage actually improving? Are risks being shared more broadly or pushed downward? Is guidance increasing along with options? Choice can coexist with strong coverage, but when choice replaces coverage, the difference matters. Setting up the next step. Once choice becomes the primary mechanism, the system begins to rely on an assumption that individuals can act as informed consumers. In the next part, we'll examine that assumption and why the idea of the fully informed healthcare consumer breaks down in practice. Next, Part 6, The Myth of the Informed Consumer. Part 6, When the system stops pretending. For years, America's healthcare debates have circled the same familiar arguments: cost, access, innovation, choice. Each side insists the problem is just one adjustment away from being solved: a different payer mix, a different incentive, a different set of rules. What rarely gets said out loud is simpler and more uncomfortable. The system no longer matches the reality it is supposed to serve. This isn't a failure of compassion, and it isn't a failure of effort. It is a failure of structure, a system built on assumptions that no longer hold. A system optimized for avoidance. Modern healthcare is not primarily organized around outcomes. It is organized around risk avoidance. Risk is shifted from insurers to providers, from providers to patients, from institutions to families, from policy to paperwork. Each step is rational in isolation. Each makes sense on a spreadsheet. Together, they create a system where no one is fully responsible for the whole. The result is not efficiency, it is fragmentation. the language that shields the problem. We rely heavily on comforting language, consumer choice, market efficiency, personal responsibility, innovation. These phrases are not lies, but they are incomplete. They work well for elective care, predictable conditions, and people with time, money, and literacy to navigate complexity. They break down when care becomes urgent, unavoidable, or human. When health stops being optional, the language stops working. Who carries the weight now? As responsibility diffuses upward, the burden concentrates downward. Patients manage billing disputes while recovering. Families coordinate care without training. Providers burn out navigating systems designed to protect revenue, not judgment. Rural hospitals absorb losses with no margin for error. None of this shows up cleanly in political talking points. It shows up in closures, staffing shortages, delayed care, and quiet financial collapse. The place the system can't avoid. There is one place where all of these distortions converge, where care cannot be deferred, denied, or negotiated in advance. The system depends on it. The system resents it. And the system refuses to fully account for it. This is not because it is inefficient, but because it is honest. It is where every upstream decision eventually lands. The political stalemate healthcare dysfunction has become politically useful. One side uses it to fundraise, the other uses it to posture. Both promise fixes that stop short of structural change. Real reform would force trade-offs. Trade-offs create accountability. Accountability threatens narratives. So the system limps forward, managed rather than repaired. The fork in the road. We are now past the point where incremental adjustments can hide the mismatch. We can continue to shift costs, narrow networks, add complexity, manage decline. Or we can acknowledge the truth that has been visible for years. A healthcare system that pretends everything is a market, everything is optional, and responsibility can always be deferred will eventually fail at the moments that matter most. This series is not about choosing sides. It is about deciding whether we are willing to stop pretending.
CODA, What We Know Now. This series was not an argument for a particular healthcare system, nor an indictment of any single group. It was an attempt to slow the conversation down long enough to observe something that usually gets buried under urgency and outrage. Healthcare in the United States does not fail because people don't care. It strains because the structure no longer matches the reality it serves. Across these 6 parts, a pattern emerged. Risk is endlessly redistributed, but rarely resolved. Responsibility is divided into pieces small enough that no one holds the whole. Language meant to clarify instead cushions the impact of hard truths. Individually, each decision makes sense. Collectively, they produce a system that functions until it doesn't. What this series set out to do was name the illusions that keep the system moving without being examined. The first illusion is that healthcare behaves like a normal market. In many places, it doesn't. Urgency removes choice. Complexity obscures price. Delay compounds harm. These are not moral failures. They are structural realities. The second illusion is that responsibility can be shifted indefinitely. Costs move, risk moves, paperwork moves. Eventually, the weight settles somewhere. Increasingly, it settles on patients, families, frontline providers, and communities least able to absorb it. The third illusion is that political disagreement is the primary obstacle to reform. In truth, dysfunction has become comfortable. It fuels narratives, fundraising, and positioning on all sides. Real reform would require trade-offs, and trade-offs require accountability. Accountability disrupts stories people rely on. What holds all of this together, often invisibly, is effort. Care still happens. Professionals still show up. Systems still stretch to cover gaps they were never designed to hold. That endurance deserves respect, not exploitation. Nothing in this series argues that healthcare must be simple. It argues that pretending it already is has consequences. The purpose here was not to provide answers, but to establish a starting point grounded in reality rather than ideology. Any serious conversation going forward has to begin with what healthcare actually is: partially market, partially public, and fundamentally human. It cannot be reduced to slogans without losing something essential. This is a pause, not a conclusion. The questions raised here do not disappear because they are uncomfortable. They wait, they accumulate, and they resurface wherever care becomes unavoidable and responsibility can no longer be deferred. Before solutions are proposed, before sides are taken, clarity matters. That clarity is the work of this series. What comes next will deal with the parts we tend to avoid, not because they are controversial, but because they force choices. Those choices will deserve their own space, their own discipline, and their own honesty. For now, this much is enough to know. But we are far from done. This was just Series 1. Series 2 starts next week.